Good evening, friends and colleagues. This is 45th Annual Conference of Mumbai Hematology Group. Today is day 3 of the Satellite Symposia. This show is managed by Mice Ideas and I'm grateful to them. Today's sessions are sponsored by Novartis. We have 3 sessions. First, myeloproliferative neoplasms. Second one on severe aplastic anemia. And third one on chronic myeloid leukemia. Each one of these is for 40 minutes, the total of 2 hours package for you from 6:30 to 8:30. We begin with myeloproliferative neoplasms. First, we have a lecture on improving outcome in myelofibrosis, early use of ruxolitinib, that's Jakavi, and survival as the treatment goal. Our speaker is Dr. Balakrishna Padate. He's MD Medicine, MRCP, FRC Path, CCST London. He's Director and Head, Hematology, Hemato-Oncology, and Bone Marrow Transplant Unit at Nanavati Max Super Specialty Hospital, Vileparla, Mumbai. Over to Dr. Balakrishna. Balakrishna, you're muted.
Sir, I'll start sharing my screen. I'll just see whether we can. So can you see the screen?
Not yet.
I have sent my presentation to Kalpesh ji. If he has...
Nirav, you have it?
Yes, sir. I'll share it, sir.
Yeah, you can.
Yes, thank you. Thank you.
I'll do it.
Sir, can you see the slide?
Yes.
Yes, please. Yes. So we'll discuss about myelofibrosis, early use of Jakavi, and survival as treatment goals. We'll go through slides and see how far we can reach. So we can go to the next slide. So this is the WHO criteria for diagnosis of primary myelofibrosis. We don't need to go into details of that. Everyone knows about it. We can go to the next slide. And this is a JAK-STAT pathway. Again, all of us know about the JAK-STAT pathway. So we'll go to the next slide. So these are the clinical criteria for diagnosis of myelofibrosis or clinical features of myelofibrosis. Normocytic normochromic anemia, increased or reduced WBC count, leukoerythroblastic blood picture, teardrop poikilocytosis, splenomegaly, constitutional symptoms, and thrombosis or hemorrhage. These are classical features that we see in patients with myelofibrosis. So we can go to the next slide. So this is a very, very important slide. So in patients with myelofibrosis, if you have JAK2 mutations, MAPL mutations, these 2 mutations, or if you have a triple negative situation where JAK2, MAPL, and CALR, all 3 are negative, in that scenario, you have a higher risk of thrombosis, higher risk of transformation to acute leukemia. However, if you have CALR mutations, you have improved survival. You are compared to triple negative patients and JAK2 positive or MAPL positive patients, you have lower risk of thrombosis and lower risk of transformation to acute leukemia. In triple negative patients, you have inferior leukemia survival compared to patients who are JAK2 and CALR mutated. And if you go down, then you have AXXL1 mutation, IDH2 1 and 2 mutation, EZH2 mutation, and SRSF2 mutation. These are called high molecular risk mutations. So these are independent markers for inferior survival associated with higher risk and associated with higher risk to transformation to leukemia. And then we go to combination of CALR and ASXL together. So longest survival is in patients. AXSL is one of the commonest mutation that we get in addition to driver mutations in patients with myelofibrosis. So if you have CALR positive, if you are CALR positive and AXXL1 negative, your overall median survival is up to 10 years. However, if you are CALR negative and you are AXXL1 positive, your survival can be as low as 2.3 years. And all other patients which are both positive and both negative fall into a median grade, which is around 5.5 years. We can go to the next slide. So these are driver mutations. Driver mutations are JAK2, both exon 12 and 14, MAPLE and CALR mutations, and high molecular risk mutations or HMR mutations or AXXL1 mutation, EZH2, IDH1, 2, and SRSF2 mutation. There are few more, but these are the commonest ones that we see in myelofibrosis, which have impact on survival and leukemia transformation. So we can go to the next slide. So this is standard IPSS score and DIPSS score that all of us know. Clinical features are included, laboratory features are included, and the classification is in 4 grades: low, intermediate 1, intermediate 2, and high risk. And based on where they fall, they have a survival, median survival of between 11.25 years to as low as 2.5 years. So we can go to the next slide. Based on these DIPPS and IPSS score, the NCCN guideline has given pathways of treatment. So if you have a low risk patient, if he is symptomatic, you could start ruxolitinib. It's FDA approved now for treatment in myelofibrosis. If you are asymptomatic, you can observe or consider clinical trial. In patients with intermediate 1 risk, similar, if you are symptomatic, patient can go for ruxolitinib. If they are asymptomatic, you could observe or can go into clinical trial. Patients who are high risk and are candidate for allogenic transplant or fit for allogenic transplant should go for allogenic transplant. Patients who are unfit for allogenic transplant should either consider ruxolitinib or fedratinib. Both of them are now licensed for first line in myelofibrosis. And in patients who are asymptomatic, should either go for clinical trial, or in patients where symptomatic anemia is there or thrombocytopenia, it needs to be treated accordingly. So we could go to the next slide now. So how did these new MIPSS or genetically inspired scoring systems have come into play in myelofibrosis, and what is the relevance of that? The reason for that is nearly 20 to 25% of patients who used to fall into DIPSS lower grade can be classified into higher grade. Now we know that XSL mutations or other non-driver mutations have a significant impact on survival. So if you have a HMR mutation like AXXL1 or IDH1 or IDH2, in spite of having a DIPSS score which falls into low risk, these patients have a significantly higher risk of transformation to acute leukemia and have shorter survival. And that's the reason quite a few of those patients, nearly 1/5 of those patients who fall into low risk or intermediate 1 category, can be upgraded or upstage into higher risk category by MIPSS or MIPSS 70 grading system. So we can go to the next slide now. So this is GIPSS score, and based on that, how do we judge the survival of patients? If you go on the look at the top, where there is a low risk patient, you have 5-year survival of 94%. While if there is a high risk patient based on GIPSS, genetically inspired scoring system, or MIPSS, if you have a HMR mutations, more than 2 HMR mutations, your 5-year survival can be as low as 14%, even if you have DIPSS score of low or intermediate 1. So we can go to the next slide. So based on the MIPSS score, patients who fall into, now you have excluded the HMR mutations, you have excluded TP53, you have excluded high risk genetic markers, and in spite of that, if patient falls into the low category based on MIPSS 70 or MIPSS, you have a low risk or a very low risk myelofibrosis, and these patients have estimated 10-year survival up to 92%. And these patients should be considered for observation alone. However, patients who have high risk molecular abnormality or HMRs and can be classified into MIPSS higher grade need to, and if they are fit for allogenic transplant, needs to be considered for allogenic transplant. And all other patients who fall into intermediate risk can be considered for clinical trials or ruxolitinib or investigational treatments. Next slide. So here is the slide from the presentation. So 21% of low risk and intermediate 1 risk IPSS patients who with inferior survival, we knew that some of these patients don't do well, but now we know why do they not do well, because quite majority of these patients would have overall survival or high risk of poor overall survival or high risk of transformation into leukemia is because they have high molecular risk mutations like IDH1, IDH2 or AXXL1. And if you have those mutations, even low risk IPSS score or intermediate 1 IPSS score patients need to be upgraded into a higher risk category. Next patient. Next slide. So HMR mutations are associated with reduced overall survival, increase progression to leukemia, and reduce leukemia-free survival. And based on that background, we'll go to the next slide now. So in patients with high molecular and low molecular risk mutations, if you give ruxolitinib or best available therapy, purely because they have higher molecular risk mutation, they do have progression-free survival, which is inferior compared to patients who do not have these HMRs and received ruxolitinib or best available therapy in that group. We can go to the next slide. So we just basically brush on Comfort 1. So Comfort 1 trial studied ruxolitinib versus placebo, and it definitely has significantly improved splenic responses as well as constitutional symptoms. And in Comfort 2, there is ruxolitinib versus best available treatment, which included hydroxyurea as well. And your splenic responses were again significantly better. The problem with ruxolitinib that it has complications like anemia, thrombocytopenia, very high discontinuation rate. Nearly half of your patient will discontinue ruxolitinib because of side effect at the end of 3 years, and they can have severe withdrawal symptom once you stop it. And it's not known to reverse the disease history. So marrowfibrosis as well as cytogenetic and molecular markers are not reversed in spite of long-term therapy with ruxolitinib. So next slide. So then what are the basic parameters? Why ruxolitinib is still used? What is its relevance? So there is if you use later and if you use early, what happens? So patients who are survived for 2 years without treatment with ruxolitinib on best available therapy have already progressed significantly in their natural history of the disease. They have significantly increased their spleen size. They have started developing pancytopenia because of myelofibrosis. So patients with increased disease severity, delay in starting of ruxolitinib and titrated doses hence started at a lower intensity because of cytopenias are associated with poorer survival in the long term or poorer response rate, poorer progression-free survival in the long term. We can go to the next slide. So the rationale of using ruxolitinib early comes from this Italian trial where they recruited 408 patients from 18 centers. And the reason why we should start ruxolitinib early, because we know that in patients who are early, they have higher dose tolerance because you don't have cytopenias. Their higher starting dose because the spleen size responses are bigger. Lower ruxolitinib dose is associated with reduced efficacy. Advanced stage disease, when you are starting ruxolitinib later, they already have advanced disease. They have pancytopenia. Some of them are already transforming into leukemia. They have larger splenomegaly. They are transfusion dependent, platelet transfusion dependent, and they have already crossed into intermediate 2 or higher IPSS risk. And that's the reason their responses can be poorer. So this is the rationale to start ruxolitinib early in myelofibrosis. So next slide. In presence of this DI-PSS and MI-PSS score, now we need to look at risk-adapted therapy. So every patient, even at low risk, can go on ruxolitinib. However, the only curative therapy for myelofibrosis is bone marrow transplant. And ruxolitinib has not really reversed the natural history of the disease. However, bone marrow transplant is associated with nearly 50% mortality, and transplant-related morbidity can be very, very high, including GVHD in these patients. And that is the reason, if both of these options are not the best options for myelofibrosis, then what do we look at? So there are many novel agents that are now coming up, which we are going to discuss in just one moment. So we can go for the next slide. What is the impact of ruxolitinib on survival? So far, we were looking at it is the drug that is used for palliative care in terms of symptom control, splenic volume reduction. Patients have survived, however, and they have no constitutional symptoms. But is there a data on survival benefit of ruxolitinib? So this is an abstract that is published in EHA in 2020. Impact of ruxolitinib on survival. This is an earnest trial, and there is a robust data from this particular abstract, which shows within the limits of observational study, the real life data supports that overall survival benefit is there of ruxolitinib over hydroxyurea alone in patients with primary and secondary myelofibrosis both. So we'll go to a little bit detail into this. Can we go to the next slide? So the results of this data suggest that in patients who have ruxolitinib, they have 7.7 years of overall survival compared to 3.4 years in hydroxyurea. And those patients who have previously exposed to hydroxyurea and now changed over to ruxolitinib, those patients also exploited that benefit of starting ruxolitinib in both the groups. So ruxolitinib definitely has an overall survival benefit based on this data. So next slide. So this is the survival curve. So propensity score matching was done in Ernest trial, and based on that, we found that there is definitely survival benefit of ruxolitinib over hydroxyurea. Next slide. So Ernest trial shows that 487 patients received hydroxyurea and 108 patients received ruxolitinib. Median overall survival was 7.7 years versus 3.4 years. There was no difference in overall survival depending on whether ruxolitinib was started as first line or after hydroxyurea. So definitely this study shows that this is a unique opportunity to provide real life evidence of ruxolitinib and its impact on the survival of patients with myelofibrosis, both primary as well as secondary myelofibrosis patients who have transformed from PV or ET as well. Next slide. Now there are many newer agents are coming up for therapeutics as a therapeutic strategy in myelofibrosis. So we know that tumor tissue growth factor beta inhibition. So that is primarily responsible fibrosis as a end cytokine that leads to fibrosis in the bone marrow. So inhibitors of TGF beta as well as interferon, PD-1 inhibitor, CALR antibody, JAK2 inhibition we already know, FLT3 inhibition, then hypomethylating agents in combination with ruxolitinib or JAK2 inhibitors or alone, as well as IMDs like lenalidomide, telomerase inhibition. All these drugs are coming up. We'll go through those drugs in one slide very quickly. Next slide. So JAK inhibitor landscape in 2021 shows approved drugs are ruxolitinib and fedratinib for first line. There are seeking approvals are pacritinib and momelotinib. Pacritinib is primarily used in patients who are presenting with low platelets count or struggling because of low platelet count, and momelotinib in patients with anemia where ruxolitinib in adequate dosages cannot be used in because of anemia. So next slide. So this is the NCCN guideline for movement after ruxolitinib and generally based on the risk stratification. Next slide. So we'll go to Jakarta 1, which is the first Jakarta trial where they have shown fedratinib significantly reduced the risk of disease progression versus placebo. The progression-free survival was much better in patients who have received fedratinib, 23.2 versus 17.5 months compared to the placebo. We'll go to the next slide and compare whether Jakarta was the fedratinib was beneficial in patients who have previously received ruxolitinib. So you can go to the next slide. So here you can see patients who have received, this is Jakarta 2, patients who have received fedratinib after ruxolitinib therapy, failing of ruxolitinib therapy, still there was medium overall survival, which was much better. So it is beneficial frontline as well as beneficial in patients who are previously exposed to ruxolitinib and stopped ruxolitinib because of any reason, maybe it's side effects or intolerance because of anemia, etc. So next slide. So about 1/3 of these patients responded to fedratinib regardless of the cause of discontinuation. And it says that patients with advanced myelofibrosis substantially responded to fedratinib in spite of receiving ruxolitinib previously. Next slide. So positioning of JAK inhibitor in myelofibrosis is patients who have in future, very recent future, patients who have platelet count of more than 50,000 would receive ruxolitinib. Patients who have less than 50,000 platelet count will go for pacritinib. Patients who have a transfusion dependent or anemia as a problem with use of ruxolitinib will go on momelotinib, and patients who have failed on ruxolitinib would possibly go on fedratinib. Next slide. These are newer agents. We very quickly touch on those. So luspatercept in myelofibrosis. So patients who have previously received ruxolitinib and patients who have not received ruxolitinib, in both groups, the transfusion independence was achieved significantly more in patients who have received this drug. This drug was used for refractory anemia with ring sideroblast type of MDS who are transfusion dependent. And now that can be used in myelofibrosis in both groups, patients who are on ruxolitinib and patients who have never received ruxolitinib. Next slide. Navitoclax overcomes ruxolitinib resistance. This can be used alone or in combination with ruxolitinib. And you could see there is a significant splenic volume reduction responses, as well as progression-free survival in patients who have previously received ruxolitinib and then can be used in combination with ruxolitinib. So this is a BCL2 inhibitor which does not have thrombocytopenia side effect like venetoclax and can be used in myelofibrosis in future. Next slide. BET inhibition, again, differentiation of megakaryocytes and erythrocytes is much better, can be used. The trials are going on in combination with ruxolitinib. So transfusion independence of both platelet and blood can be better when used in combination with ruxolitinib. Next slide. Then there is pelabresib in combination of ruxolitinib. If you look at the trial data, shows 76% of these patients have baseline hemoglobin of less than 10 in arm 1 and arm 2. And you could see over a period of nearly 20 to 12 weeks, so approximately 4 months to 24 months, majority of these patients have significant reduction in transfusions, blood transfusions, after use in combination with ruxolitinib. Next slide. So nearly 35% transfusion independence conversion from patients who used to regularly use blood transfusions for myelofibrosis. This is LSD1 inhibition, again used in combination with ruxolitinib. Next slide. Phase 2 data about bomedemstat. So this is again transfusion independence as well as splenic response rates, significantly better when used in combination with ruxolitinib. Next slide. So this is IMLL stat. So this is again treatment for used for patients with ruxolitinib and combinations of IMLL stat. So bone marrow fibrosis improvement is seen in nearly 40% of patients. So some of these drugs are associated with disease natural history reversal as well, not only transfusion independence. They do have survival benefit. Progression-free survival is definitely improved. Transfusion independence they have achieved, as well as there is a splenic volume reduction responses in majority of these newer agents. Next slide. So what are the gaps? So what do we still don't know? So what is the role of this mutation? We know that quite a few of these patients, we have HMRs like AXXL1 mutation, IDS2 mutations. But based on this mutation, can we choose one of these drugs? Or based on these biomarkers that we have got, that these patients have TGF-beta raised, like IL-2 raised in patients with COVID, can we particularly select a particular drug or not? Or combination with ruxolitinib or alone or not? We don't know that information yet. Disease modifying therapies and therapies, can they extend the survival? We do have some initial information that they do have impact on overall survival, but that needs more studies, as well as treatment options for patients who are refractory to JAK inhibitors like ruxolitinib. We know fedatinib is now licensed first line, and in Jakarta 2 also suggested that it can be used in patients where there is a failure or intolerance to ruxolitinib. However, is there a real information long term? So those are the gaps that we need to still understand in myelofibrosis treatment. So that is the last slide of mine. Thank you.
Thank you, Dr. Balakrishnan, for that lovely lecture. And we now have the panel discussion. This panel discussion is on the same subject. It will be moderated by Dr. Balakrishnan himself. And the panelists are Dr. Arihant Jain from Chandigarh, Dr. Ankit Rayani from Ahmedabad, Dr. Venkatesh Ekbote from Kolhapur, Dr. Jeevan Garg from Kolkata, Dr. Ashutosh Panigrahi from Bhubaneswar.
Sure.
Yes. And Dr. Nitin Gupta from New Delhi.
I just wanted to correct. I'm from Aurangabad. Sorry, sir.
I'm so sorry for that.
Sorry.
So
No problems.
This session will
Thank you.
go
Good to be there.
This session will go up to 7:10 p.m. So Dr. Balakrishnan, I request you to stop somewhere at 7:10. Go ahead.
Yes, sir. So, sir, again, do we have the slides for the presentation, Kalpesh ji? I will try to share the window, but I have emailed the slides as well. Let's see whether I can share.
I did not receive it. If you can share it, I'll just check it.
I'll share it right away, Kalpesh ji. Just now. Trying to share the screen at the same time. Let's see whether it does.
Sir, first you open the presentation in the background.
It is open. Yes.
Okay.
It is
then
open.
go to Zoom.
Yes.
Yeah.
Share screen.
Share screen. One window will open where the presentation open. Click on that window where the presentation open. Just click and share it. It will come.
Yes, I did that, but it still doesn't share. I clicked on the Microsoft PowerPoint, but it still doesn't share.
Just
anyway, so now I'm just emailing you to right away. Sorry, give me 1 second. It's still loading on your email. I don't know why it is not sharing. So all the panelists have the cases that I have sent. Can we start the first case without the
Yes.
screen?
Yes, you can
Yes,
go.
sure.
So these are the two cases that we have treated. All the panelists have those, and the questions are there as well. So meanwhile, while I am trying to email it to Kalpesh ji, I will start the first case. So we have here a 63-year-old male who was diagnosed with primary myelofibrosis, JAK2 positive in 2018. He presented with left lower quadrant discomfort with splenomegaly with early satiety. Baseline CBC suggested that his hemoglobin was 10.6, WBC count was 12,600, and the platelet count was 98,000. There were no circulating blasts in the peripheral blood. So based on this data, what is the DIPSS score in this patient? If one of the panelists can answer that.
Yes, I think it is low to intermediate 1 because neither are the platelets less than, I mean, there's just the platelets which are less than 1 lakh, but that's also very marginal because it's like 98,000. So on smear,
Yes.
probably they will be more, but given that information, I would classify intermediate 1. Yeah, from the.
So intermediate 1. Meanwhile, Kalpesh ji, I have sent the presentation to you right now. It is
I will
emailed
check, sir.
already.
Just a second, I'll check it,
Yes.
sir.
Yes. So now we have a patient who is 63-year-old and who has DIPSS score of low to intermediate 1. He has bone marrow fibrosis of grade 3. And at the time of diagnosis, he was not treated by us. He came for a second opinion 2 years after he started his treatment. So his genetics showed 46XY normal conventional karyotype, and he had TET2 and AXXL1 positive. So if another panelist can answer me, what are the HMRs present in this case? High molecular risk mutations present in this patient.
Hello, hi, Dr. Nitin Gupta here from New Delhi. So again,
Yes.
as you already mentioned in your talk, so the patient has high risk molecular mutations, AXXL1 mutation, and other, I think the second one is, so both are high risk
So the
mutations.
second mutation is TET2 mutation. TET2
Okay.
mutation
So
is not
AXL
considered as HMR in
right.
myelofibrosis.
So AXXL1 is a high risk mutation, not the TET2 one. All right. So again, but that patient will be classified as a high risk based upon the molecular phenotype. And although by using the DIPSS, as Venkatesh has already said, he falls into low risk category.
Right.
So yeah, of course, but yes, this mutation will put him on the high risk category, and we know that they have kind of rapid progression to AML, and they become more symptomatic, and their progression-free survival is less compared to the other DIPSS categories.
Right.
Dr.
Now,
Balakrishna,
yes.
I'll just share the slides, sir.
Yes, please. Thank you. Excellent. Very good. So we'll go to the third slide. One more. So based on the DIPSS score, Dr. Ankit, what would you offer him as a treatment option? And based on the MIPSS or genetically inspired score, what would be the treatment option?
So basically, DIPSS score is low, and the patient does not have any other symptoms. Constitutional symptoms are not given in the history, like weight loss or fatigue or sweating, and fever. Early satiety is because of splenomegaly, and that does not is not included in the constitutional symptoms. So by DIPSS or IPSS alone, the patient may be kept on observation only, because the platelet counts are low, but that not very low, and the patient may deteriorate very early and may progress from low risk to high risk because of presence of high risk mutation. So based on newer classifications like MIPSS 70 or GIPSS, ideally patient should go for transplant because age is 65. At least he should be put on JAK2 inhibitors.
Perfect. So that answers your last question as well, because you have upstaged the patient based on GIPSS and MIPSS score. Now, someone who was going to be only observed. Now we looked at in the previous presentation that ruxolitinib will have benefit on progression-free survival, and there is some data on overall survival as well. So if he is not fit for transplant, he should at least go on ruxolitinib first line. So next slide,
can
please.
I come in here, Balkrishna? Can I just make one
Yes,
small point?
please do. Yes, yes.
Right. So about this MIPSS, they have said that
Yes.
at least 2 or more mutations qualify
That
an
is correct.
upstaging.
Classify them
That
into
is
high
one
grade. That
thing.
is correct.
And the second thing is
Second,
absence of CALR. So absence of CALR will constitute 1 point.
Absence of CALR will give him 2 points and MIPSS 70.
Yes.
70
So,
plus, sorry. MIPSS 70 will have 2 HMRs, and MIPSS 70 plus will have absence of CALR as 2 points, and MIPSS 70 will give absence of CALR as 1 point. So he'll still be classified as high risk, and in ideal world, if he's fit, should be considered for a transplant. Now I will go through it and see what happened to him in absence of transplant.
my doubt is whether this is an early, right? No, my only question is whether, yes, he is for a transplant for sure, but my question is whether he qualifies for ruxolitinib therapy irrespective of that, based on the HMR status. Because as you showed in the previous talk, the HMR status, ruxolitinib does not alter prognosis in patients who have an HMR status by the MIPSS. They are definitely high risk, I agree, but how does ruxolitinib alter their status? There's only data from the Ernest trial where they have not really looked at the HMRs, whereas the actual trials.
So the slide that I've shown is in patients with best available therapy and in patients with ruxolitinib who have HMRs. HMRs, although they have poorer survival compared to poorer progression-free survival compared to patients who do not have HMR, that doesn't mean that you don't initiate them on ruxolitinib therapy.
Yeah,
so they would definitely
I'm
have
saying
something.
you should. It's not that it is a contraindication. All I'm saying is, does it really qualify the patient to be initiated on ruxolitinib irrespective of the symptoms? I'm not talking about whether the patient should be considered at all. But all I'm saying is HMR being the only sole criteria, should it be used as if and it should supersede the symptoms, is what my question is actually here.
Yes. So there is a very good paper that is published in 2021 called Primary Myelofibrosis, 2021 update on diagnosis, risk stratification and management. It is by Professor Taferi from Minnesota, and it says that in GIPSS score,
I've read that paper.
Score, yes. If you have a higher risk stratification or higher risk category of myelofibrosis, you should initiate them on therapy, and that is there even in NCCN guidelines now. That in asymptomatic patients, yes. If you have low risk category, no, but patients who have high risk, they have definitely have high risk of transformation into leukemia. So initiation of ruxolitinib, if not transplant, should actually be done, I feel. Next slide.
Dr. Balakrishnan, I want to add something. So this patient has CALR is negative and one mutation is present. So this will fall into intermediate risk category. This will not in the high risk category. So one HMR is 2 score and 2 score for a negative CALR reticulin. So total will be the 4 score. So this will be intermediate risk category.
So even in intermediate risk category, the AXXL1 mutation is, if you look at MIPSS score, it is classified as HMR. So in these patients, they definitely have a higher risk of progression to leukemia, even though there is one. So initiation of therapy based on the risk stratification is different, but they definitely have a risk of poor survival and higher risk of transformation into leukemia. So that needs to be considered when we look at starting therapy or looking at them in monitoring. So we'll go into the case. You will understand what's happening in to him in future. So next slide. So next slide again. This we have looked at previously. Next slide again. Next slide, we have looked at this. Again, so this is the slide that Dr. Ekbote was talking about. So if you have HMRs, they
Yes.
have poorer progression-free survival. That doesn't mean that you don't initiate them on treatment when you have a patient with high molecular risk mutation in front of you.
My question was only about ruxolitinib as treatment. My point
Understood,
was only about ruxolitinib as treatment and not to select patients for therapy. Definitely, he should receive
Sure.
therapy.
Understood.
Absolutely true about that. Yes.
Understood. Next slide.
Okay, continue.
Next slide again. Again, next slide. Next slide. Next slide. So what happened to these patients was you started on ruxolitinib 10 milligram twice in a day and titrated up to 15 milligram after a year or so. Possibly, what patient tells me that he didn't consent with the doctor initially to start treatment because of whatever reasons, and he had complete resolution of systemic symptoms as well as spleen reduction. However, in March 2021, which is around 2.5 years later, he started developing worsening splenic complaints as well as night sweats, mostly in the night, mild, and RBC transmissions, as well as he had palpable splenomegaly. And if you can look at that, he has got 3% blast into the peripheral blood, circulating blast. So next slide. So what is your treatment option now? And unfortunately, what happened in between these 3 years, he had got a cardiac event during COVID time, and then he's become essentially unfit for the transplant. So what would be, considering that, what would be your treatment option now?
Definitely a reevaluation is required. Based on that, if any new mutation has occurred, accordingly we have to proceed. So anyhow, second JAK2 inhibitor will be a option for this patient if at all it is available. And if he has progressed, then we have to think of adding some. What is available with us is a hypomethylating agent that we can add in this situation.
Perfect.
What about venetoclax?
Dr. Right.
Curious.
So venetoclax
Because it's
data,
available.
Navitoclax. Yes. I don't think there is any data particularly of venetoclax and ruxolitinib together in a progression. Of course, first thing what you do is you do a bone marrow, find out whether he has transformed or it is progressing into a blast situation, and based on that you would treat him. If he has
assuming that it is
into acute.
So
the treatment will be entirely different.
So venetoclax will be an option. Venetoclax will be an option if there is AML transformation and unfit for a high risk treatment. That means high dose chemotherapy. That will be.
That is correct. Absolutely correct. And Dr. Jain, would you answer
in this
last
particular
question?
scenario, secondary leukemia?
Yes, absolutely. So particularly because of those HMRs, he has a high risk of transformation. So we will do a bone marrow and restage them. So Dr. Jain, do you want to answer the last question? What is the role of splenectomy and splenic irradiation? And then I'll tell you what we did with this particular patient. Dr. Jain, you are on mute.
So the role of splenectomy is predominantly in very symptomatic cases who are bleeding and there is no other option available. And the same holds true with splenic irradiation. Sometimes they have like really painful spleen and just as a palliative treatment for symptom relief. But we must understand that they may not be transforming the disease process per se. So very select patients heavily symptomatic because of spleen or big infarcts, pain, all those things.
Correct. So in mild to moderate splenomegaly, there is no role of splenectomy pre-transplant as well as for treatment of myelofibrosis. But there is some data, and it can be associated with complications, including increase in transfusion dependence as well as infections. There is some data that in patients with severe splenomegaly, splenic irradiation and partial splenectomies or splenectomies pre-transplant can change the survival post-transplant. That is a very immature data. So in our practice or in general, no one would consider splenectomy or splenic irradiation before the transplant. So I have not heard or we have not done that before. So these particular patients we are considering for fedratinib. It is licensed now for patients who are failed ruxolitinib, and we are acquiring that drug in next 15-20 days time. So fortunately, we are getting hold of fedratinib for him, and he should hopefully he should respond. So that's what we are doing. He is unfit for transplant currently, and bone marrow does not show clonal or morphological transformation. He has not transformed into acute leukemia, and there is no clonal evolution in the molecular markers. Molecular markers still remain the same. So that's what we are doing with this patient. So we have got like 3 minutes. Do we want to go to the next?
No, Balakrishna, your time is over. You can
Okay.
conclude this now in 10 seconds.
Sure. So I would just thank all the panelists for being there, looking at the case and giving their contributions. Thank you so much, sir.
Thank you so much.
Thank you.
Thank you, Dr. Bal.
Thank you, sir. Thank you.
Thank you, sir.
And
Thank you,
we'll
Dr.
move to the
Agarwal.
second part of the session, which is on severe aplastic anemia. We have lecture by Dr. Radhika KK. The title is Innovative Journey of Eltrambo-PAG, that's Revolet, and Addressing the Unmet Need in Severe Aplastic Anemia. Dr. Radhika KK is Associate Professor, Department of Clinical Hematology at Nizam. You have exactly 14 minutes for your presentation.
Yes, sir. Thank you, sir. Thank you, sir. And thank you, organizers, for the opportunity. I'm going to share my slides now, sir. Thank you, everyone. Thank you for the opportunity. I'm Dr. Radhika, hematologist from Nizam Institute of Medical Sciences, Hyderabad. The next 15 minutes, I'm going to take you through, 1 second, sir. Sorry, sir. Yes, sorry. So the next 15 minutes, I'm going to take you through the innovative journey of Eltrambo-PAG in severe aplastic anemia. So aplastic anemia is a rare life-threatening bone marrow failure disorder everyone knows here. It's characterized by pancytopenia, a hypocellular bone marrow due to immune-mediated attack on bone marrow. It's associated with high mortality rates of more than 70% with supportive care alone. There is no single test which provides diagnosis of aplastic anemia. Diagnosis is a process of excluding other bone marrow failure conditions. Coming to the treatment strategies, the treatment is stratified based on the age. So anybody who is less than 35 years who has a HLA matched sibling, the upfront patients are to be taken up for an upfront allogenic bone marrow transplant. Even if the patient does not have an HLA matched sibling, if it is a children, still we consider an unrelated donor or an alternative donor transplant upfront. So less than 35 years, if not children, in adults, if the patient does not have a HLA matched sibling, probably we push the patient towards an immunosuppressive therapy. Between 35 to 50 years, patient has a HLA matched sibling, it is a bone marrow transplant is the first choice. No match, it's an immunosuppressive therapy. More than 50 years, we invariably push the patients towards immunosuppressive therapy as a first line, as a first treatment option. For many years, the focus in the clinical development of novel non-transplant therapies for severe aplastic anemia has been on intensifying the immunosuppressive therapy. It all started in 1960s when corticosteroids have been used in aplastic anemia with approximately 10% response rates. A decade later in 1970s, ATG came into the picture with around 40 to 50% response. Although hematological response or recovery with ATG was observed in 40 to 50% patients, the addition of cyclosporine increased this rate to 60 to 70% in 1980s. In 1990s, salvage ATG concept came in with approximately 30% response rate. But what has been noticed is most of the response are partial, just sufficient to have transfusion independence. So the possibility of intensifying immunosuppression further by addition of a third drug to the horse ATG cyclosporin like MMF, sirolimus, or substituting horse ATG for more lymphocytotoxic agents such as cyclophosphamide, rabbit ATG, and alemtuzumab has been explored in many prospective studies. However, surprisingly, with this, all these studies yielded disappointing results. So these are multiple studies, prospective randomized studies, which have been done wherein a third immunosuppressive agent has been added to the standard ATG cyclosporine with no difference in response, relapse, or clonal evolution or survival. So all the investigations, in a nutshell, we can say that they all failed. These all studies led to the notion that a ceiling has been reached with regards to exploring more intense immunosuppressive regimen in severe aplastic anemia, and the standard immunosuppressive regimen still remains HORS ATG and cyclosporine in severe aplastic anemia. The unmet needs in the first-line management of severe aplastic anemia go this way. Approximately 70% of SA patients respond to IST, and that is a ceiling. That is a ceiling cutoff. Majority of the hematological responses observed following initial ATG cyclosporine are partial, with only a few percent, approximately 10% patients achieving a complete response. It is important to achieve a complete response because early and higher quality of hematological responses lead to lesser relapse probability, significantly better survival at 5 years, and less risk of loss of chromosome 7. Apart from that, the other unmet needs are about 1/3 of the 1/4 patient do not respond. Approximately 30 to 40% of responders relapse, and approximately 40% of unresponsive patients will die within 5 years of diagnosis. Therefore, something more needed to be done beyond ATG cyclosporine. So multiple prospective studies have been done at a global platform which explored the option of immunosuppressive therapy in patients with ineligible for hematopoietic stem cell transplant, and they found that almost all the trials found that the response rate was somewhere in between, somewhere approximately nearing 70%, and most of the responses are partial. So the prevailing notions for the lack of response, why a lack of response to immunosuppressive therapy in severe aplastic anemia? The prevailing notions could be because the autoreactive T cells, that may survive immunosuppressive therapy, and or significant destruction of the more primitive hematopoietic compartment hindering the sprout of progenitor cells after the autoimmune insult was controlled. And in minority of cases, probably a cryptic underlying genetic defect was also contributing to unresponsiveness to IST. The notion of insufficient marrow unable to recover from a severe stem cell deficit became more preponderant as hematological response rate did not improve despite intense IST. So many trials have been explored by adding stimulating agents like EPO, GCSF, stem cell factor, interleukins, but with no survival benefits. So since the approval of HORSE ATG decades ago, there was a long hiatus in therapies with activity in severe aplastic anemia. However, the scenario changed in 2014 when Eltrombopag, a thrombopoietin receptor agonist, was approved for SAA after an insufficient response to initial IST. So TPO is first shown in 1994. Initially, it was associated with megakaryocyte stimulation and platelet production, but later on, it was found that TPO has an important role in stem cell proliferation and its maintenance because of the multiple evidence which I have mentioned down. Thus, based on this evidence, it was concluded that TPO mimetic could, in theory, be active in ameliorating marrow function in aplastic anemia and associated disorders. And then people explored the use of this agent in aplastic anemia. So the mechanism of action, this is the mechanism of action, it acts as a TPO receptor and stimulates the proliferation. Initially, it was thought that it stimulates only megakaryocytes. But later on, it was found that it enhances the expansion of human stem cells and progenitors in the bone marrow in vitro. It has also been found that it acts at a different site than the regular in-house TPO, thereby preventing competitive binding and potentially allows both molecules to have an additive effect on cell signaling. So it acts in synergistic with the in-house TPO. Apart from hematopoietic stem cell enhancement, Eltrombopag also has other multifactorial functions, like it promotes a tolerance, it causes immunomodulation, it also enhances iron chelation, thereby further strengthening its use in severe aplastic anemia. So coming to the rationale for addition of Eltrombopag in the first line severe aplastic anemia, as we all know that the principal mechanism on bone marrow failure in severe aplastic anemia is an immune-mediated destruction of hematopoietic stem and progenitor cells, resulting in a profound hematopoietic stem cell depletion. But why we have a capping up to 60 to 70% response with IST? Why not? Why are we not able to go beyond that? Probably because of the severe stem cell deficit, which is, and the second reason could be autoreactive cells which are not responsive to immunosuppressant. So we needed to overcome the reasons for unresponsiveness. So the thought came in, how about adding complementary drugs which can act at different sites by different mechanisms, which can result in earlier and robust hematological response. So we explored the intensification of immunosuppression by adding multiple immunosuppressants like ATG, which lyses lymphocytes, cyclosporine blocks the T cell function, and on the other side, adding an agent at the stem cell level which can improve the expansion ability of hematopoietic stem cell, like Eltrombopag, which stimulates the early progenitor cells causing trilineage response. So by addition of different agents which act at different levels for different mechanisms of action, probably we can explore earlier and a more robust hematological response. So that was what was, the failure to respond to IST reflects the residual stem cell. The lesser the residual stem cells, the increased probability of failure. So Eltrombopag, by increasing the stem cell number in the bone marrow, it decreases the probability of failure and increases the probability of recovery. So that's how that's the mechanism of eltrombopag usage. So coming to the clinical evidence of eltrombopag, the clinical trials of eltrombopag in severe aplastic anemia. Here are the first attempts with eltrombopag, which was performed in 43 patients with refractory severe. It was initially utilized in refractory severe aplastic anemia. This is a non-randomized phase 2 dose-escalating ramp-up study from the NIH. This eltrombopag was initiated at a dose of 50 mg, and then dose escalation was performed every 2 weeks by 25 mg to a maximum dose of 150 mg, because nobody ever knew what was the exact dose which needs to be initiated upon. So it all started with a low dose of 50 and then escalated to a maximum of 150. And the results showed that 40% of the people, 17 out of 43 patients, 40% response rate was seen at the end of 3 to 4 months. The responses were durable, tri and bilineage. Patients became transfusion independent, and no new adverse events were observed with eltrombopag. 5 patients attained robust response and maintained this response even after eltrombopag discontinuation. Therefore, they concluded that eltrombopag is the only TPORA indicated for treatment of patients with refractory severe aplastic anemia. So this was how eltrombopag got introduced into the severe aplastic anemia initially in the refractory cases. Then came the famous NIH study. The promising data of the previous study, the ramp-up study, led to the NIH study for severe aplastic anemia, SAA treatment-naive patients using eltrombopag first line in addition to horsetic and cyclosporine. So this is an investigator-initiated, non-randomized, single-center, phase 1-2 study investigating immunosuppressive regimen of horsetic and cyclosporine in combination with eltrombopag as an experimental therapy in subjects with SAA who had not received any prior definitive therapy. So here it was used upfront. So these were the exclusion criteria: Fanconi's anemia, severe liver impairment, the clonal myeloid neoplasm, cytogenetic abnormalities were all excluded from the study. Given the optimal dosing of the previous pilot trials, a starting dose of 150 mg was chosen in this particular study. So for adult patients, a 150 mg dose was chosen. Between 6 to 11 years, 75 mg of eltrombopag was used, and for pediatric patients, 2.5 mg per kg body weight was considered. So this is the design of the NIH study. So we have 3 cohorts, cohort 1, 2, 3. It all started with cohort 1. They have found that we all know that liver enzyme abnormalities were seen in approximately 10% of the patients on ATG and cyclosporine. Thus, the initiation of eltrombopag was delayed by 2 weeks after immunosuppressive therapy until the liver enzymes are normalized or near normalized in the initial cohort, that is the cohort 1. So the eltrombopag was delayed by 2 weeks because we wanted the liver enzymes to be normalized. In the subsequent cohort, that's the cohort 2, eltrombopag was added on day 14 like the cohort 1, but the duration was abbreviated to 3 months. So in cohort 1, it was continued for 6 months. In cohort 2, the duration was abbreviated to 3 months because of the concern for clonal evolution with long-term use of the agent. It was found that when they have reduced the duration to cut short the duration to 3 months, there was a small decline in complete response rate, and also there was some loss in responses between 3 to 6 months, which again led to the resumption of the 6 months course in the subsequent cohort, that's the cohort 3. So in cohort 3, eltrombopag was added on day 1 and continued for 6 months. The primary endpoint was complete response at 6 months in the safety. The predominant age group in this trial was 18 to 64 years. So coming to the results, the overall hematological response at 6 months was 95%, an excellent response, with the complete response seen in 58% at the end of 6 months in cohort 3, when compared to 61 and 47% respectively in cohort 1 and 2. So 94% overall response with 35% complete response seen in cohort 3 was an astonishing results when compared to the historical IST hematological response of 60 to 70% with a complete response of 10%. That means the results of cohort 3 represented nearly 6 times increase in the complete response when compared to the historical 10 versus 35, and almost double the complete responses when compared to the cohort 1 and cohort 2. So based on this study,
please conclude in 30 seconds.
Yes, sir. Sure, sir. So the simultaneous initiation of all drugs on day 1 seemed to be optimal. The overall survival was 97% and 99% when censored with stem cell transplant. The bone marrow cellularity has been significantly increased after the introduction of eltrombopag. Initially, the cyclosporine was stopped at 6 months, but then a good number of cases relapsed back. So it was concluded the cyclosporine be continued at a low dose up to 2 years. There was a clonal evaluation which occurred in 8% of the patient, but the results were similar to that of the historical studies. The eltrombopag was pretty safe. There was some liver enzyme elevation seen, but not significant enough. The similar kind of studies were explored in pediatric patients, but in pediatric patients, the response was not dramatic like how it was seen in adult patients. So this is just one sentence. So this is a race study which was comparing the ATG cyclosporine to ATG cyclosporine plus eltrombopag, and they found that the overall response of this study showed that at 6 months, the overall response was 41% in patients who received ATG cyclosporine compared to 68% in patients who received ATG cyclosporine eltrombopag.
Dr. Radhika, we will stop here. Thank you very much.
Thank you, sir. Sorry for exceeding the
so
time.
Sorry.
Thank you very much.
We move on to the panel discussion. Dr. Radhika can join the panel. And this panel discussion is moderated by Dr. Tufan Dolai, Professor and Head, Hematology Department, NRS Medical College and Hospital, Kolkata. The panelists are Dr. C.S. Ranjit Kumar, Hyderabad, Dr. Sushil Selvarajan, Vellore, Dr. Tusti Ganguly, Kolkata, Dr. Avinash Singh, Patna, Dr. Kundan Mishra, Delhi, Dr. Upendra Sharma, Jaipur, Dr. Seema Bhatavdekar, Vadodara, Dr. Riya Balikar, Nagpur, and Dr. Vikas Goyal from Raipur. So over to the moderator.
Thank you, sir, and good afternoon, everybody. Thanks for the giving opportunity, Dr. Agarwal and the Mumbai Hematology Group. So, host, please share my slide, please. Yes. So, I will be the short panel discussion in the 25 minutes. The topic is the innovative journey of the eltrombopag. There is a referent in addressing the unmet need in severe aplastic anemia. Please, next slide. Next slide, please. So you know the plastic anemia is the pancytopenia and hypocellular marrow. We know that 2 out of 3 cell line will be the less. That is, along with the bone marrow cellularity will be less than 25%. Then we can diagnose that patient has a plastic anemia. Next, the incidence of the plastic anemia. Next slide, please. The incidence of the plastic anemia, you know about the North America and the Europe, there is a repeated incidence there, but unfortunately into the Indian perspective, we exactly don't know the incidence of the plastic anemia. Next slide, please. In terms of this, basically the immune-mediated destruction of this hematopoietic stem cell. And more important is the oligochondral T cell expansion that leads to the destruction of the immunomodulatory stem cells. And ultimately that leads to the apoptosis. Okay. May I audible, please?
Yes, audible.
I am audible?
You are audible, sir.
Yes, sir, you are audible.
So the important thing is that in terms of the diagnosis, you know the bone marrow biopsies becomes very essential. Then we confirm the diagnosis of the aplastic anemia. In terms of the treatment of the plastic anemia, apart from the supportive care, there is a definitive therapy is there called bone marrow transplantation, the antithymocytic globulin, and the cyclosporine. Next slide, please. And more recently, next slide, please. More recently, the eltrombopag also has been added in our armamentarium for the treatment of the plastic anemia. So next slide, please. So my first question is that how to treat the plastic anemia if there is no HLA match donor? So Dr. C.S. Ranjit Kumar, can you take this question?
Yeah, thank you very much. So if there are no HLA match donor, so we basically like divide the patients for the treatment of aplastic anemia based upon the age. So probably like those who are having a match related donor less than 45 years of age, probably we would consider the allogenic stem cell transplantation. So if they don't have a matched donor, so options are 2 options. So one is to consider the immunosuppressive therapy, or based upon the data of meta-analysis from the severe aplastic anemia from the EBMT, you can consider the haploidentical stem cell transplantation. And those patients who are more than 50 years of age, those who are not fit for the stem cell transplantation, we would probably consider the immunosuppressive therapy with cyclosporine and ATG with L-thrombopag. So that would be like optimal therapy for the patients who are more than 50 years of age.
Right. Next slide, please. As Ranjit has rightly pointed out, so before the era of the Revolate, that the HLA as sibling donor is the important thing. We decide our immunosuppressive therapy or the transplant. If there is no HLA as sibling donor, we go ahead with the horse ATG plus cyclosporine. Next slide, please. So in terms of this, the fact of the ATG, in case of the Indian setting, because we know the ATG plus cyclosporine we use in our several group of the patients. So I go to the doctor, the Sushil Silvaranjan, in terms of this, his viewpoint of this, the fact of the ATG and cyclosporine in Indian perspective. Next slide, please.
Hello.
Yes, please.
Yeah, am I audible? Yeah, sure. So essentially, while practically, as you said, the real world scenario often differs because most of those patients, especially in our scenario, will often present with infections, which pretty much most of the patients will not be able to be given ATG upfront. Even especially in the elderly group, when they come with infections, often they don't even clear despite appropriate antibiotics and antifungals. And in that group, therefore, a significant number of them will have to go for upfront allogenic as feasible, because at least in the allogenic, there is a time point for rapid recovery. And then subsequently, the GVHD can be taken care of post engraftment. But these are, in our scenario in India, including finances and the infection presentation complicates the standard algorithm, which is why the real world scenario is different from the algorithm.
Absolutely right, because in Indian perspective, sometimes the response rate is maybe slower, around the 50% patient will become responded, and sometimes the percent response is the more common. Sometimes the patient may respond even after 1 year also. And as you rightly pointed out, infection is the important pointer. That's ATG plus cyclosporine is very difficult to give in some point of time. Next slide, please. So in terms of the improving the response rate with ATG plus cyclosporine, so any role of adding the other drugs in standard ATG plus cyclosporine? Dr. Tushti, please.
Sir, actually there have been several trials. Yes, thank you, sir, for that question. There were actually there were actually several trials to identify the action of other drugs since it's an immunosuppressive therapy. So first they were thinking that whether to add steroids to it. So they did add, there were some studies where they added steroids to it. And what they found out was other than increase the risk of infection, the steroids didn't have any more increased response. Same thing happened with anabolic steroids. There was no incidence of increased response. Then they decided on trying with other immunosuppressants like mycophenolate mofetil and cyclosporine A, and both of them did not show any significant improvement over ATG cyclosporine. There have been trials of using GCSF to improve the outcomes of patients, but other than probably reduce the duration of neutropenia and reducing the amount of septicemic episodes in patients, of some patients with ATG cyclosporine, there was no increased evidence. One Japanese study did show there was an improved response with GCSF, but there was an EBMT trial subsequently which did not show any increased response. There have been other trials like things with alemtuzumab. They also did not show too much improved response. Alemtuzumab did show response in patients, particularly in the refractory setting. And there were also trials with higher doses of cyclosporine and moderate doses of cyclosporine and increase or changing the source of the ATG, particularly in several countries where horse ATG was not available. They tried with rabbit ATG, but even that rabbit ATG horse ATG in any of the studies. So other than any of the drugs, probably L-thrombopag became the new drug which did show efficacy. Other than that, none of them have shown any sustained or a significantly improved response over ATG cyclosporine.
Right. more recently, the Eltrombopag has been there for adding the third drug with ATG and the cyclosporine. Next slide, please. So move to Dr. Avinash. So what is the rationality for adding the Eltrombopag with ATG and the cyclosporine?
So Eltrombopag, it acts on TPO receptor, which are not only present over the megakaryocytes but also on the stem cells and early progenitor cells, and by which it leads to more increased number of stem cells and early progenitor cells. As we have seen in the presentation by Dr. Radhika, that more number of stem cells, there is higher chances that immunosuppressant will work. Second, there is evidence that it has immunosuppressive effect. So whatever immunosuppression we have with ATG cyclosporine, it is going to add. And third, it inhibits the interferon gamma, which leads to apoptosis of hematopoietic stem cells. So these are the three mechanisms by which it leads to better response in aplastic anemia patients, acquired aplastic anemia.
Next slide, please. So as Avinash rightly pointed out, is sometimes the stimulates the hematopoietic stem cell. So there is a multi-lineage hematopoiesis will be there. So our aplastic anemia patient will be benefited. Next slide, please. And this cartoon is already shown to us. So there is the immunological attack, and another in the way of the mechanism that by giving the Eltrombopag, we try to preserve the stem cell that have been lost by our immunological attack. Next slide. That's why the Eltrombopag has been used. Next slide, please. So it basically stimulates the recovery of the bone marrow by one way immunological attack, another is the increasing the stem cell number. Next slide. Next slide, please. Next slide, please. So the people have been trying to adding the Eltrombopag. The people usually try it in the relapse and the refractory setting. So I move to Dr. Kundan. The role of the Eltrombopag is salvage therapy in the relapse and the refractory setting. What is your opinion in real world scenario? Dr. Kundan, please. Dr. Kundan is available?
So Dr. Kundan is not in, I think.
Okay. Anybody can take this question?
Dr. Ria here, sir.
Yes, yes, please.
Yeah. So there is a lot of data, and Eltrombopag is being used in patients who have relapsed after HOS ATG. The upfront therapy for these patients would be transplant or Abbott ATG, but in patients who cannot tolerate this therapy or are not willing for the same, Eltrombopag as a single agent is a good drug. The response rate that has been studied is around 40%. But problem is, after stopping the drug, many of the patients relapse. Around 5% would still continue to maintain response with the drug.
Right. Next slide, please. So the next slide. So Eltrombopag is tried. There is a literature of the landmark publication in the Blood Journal and also into the NEM journal by giving the Eltrombopag in relapse and the refractory setting. Next slide. So there is a next slide. There is the improvement of the tri-lineage hematopoiesis and 40% response rate. We already showed in the slide. Next. And not only the tri-lineage, but the increasing incidence of this, the platelet response, the hemoglobin, and the ANC response individually, 24 and the 36% of the cases, it will improve in case of relapse and the refractory. Drugs is quite effective for the treatment of the patient with the aplastic anemia. So next slide, please. So in Korea, please, in upfront setting, how do you treat?
Yes, sir, definitely. In patients who are not eligible for transplant, then the upfront therapy that we use now, that we prefer, is the triple therapy with ATG, cyclosporin, and Eltrombopag, 150 milligrams. And this is an excellent combination. Before the introduction of Eltrombopag, the response rate overall was to the extent of 50 to 60% in aplastic anemia patients with just ATG cyclosporin. With addition of Eltrombopag, it has jumped up to the extent of 90%. and with a complete response of around 60 to 65%, which is very good, very good, considering that the patients with ATG cyclosporin, many of them eventually even relapse following treatment. L-Thrombopag patients again have a sustained response to therapy. So I would say upfront, this combination is an excellent combination. Romiplastim also can be used upfront in a plastic, but the data with L-Thrombopag appears more promising. Thank you.
So initially you start with the 50 mg or it is 150 mg?
150 mg, sir.
Right. Next slide, please. Next slide. Next, please. So this is the landmark paper. Next. Next, please. Next slide. Next, please. Next, please. Next slide, please. So this data has been recently published in the upfront setting. So cyclosporin plus ATG vis-a-vis the cyclosporin ATG plus L-Thrombopag, there is a significant response rate is there. Next slide, please. In the phase 3 study. Next slide, please. So there is a significant hematological improvement is there if you add the L-Thrombopag with the ATG plus cyclosporin. Next slide. And there is overall survival advantage is there after adding of the L-Thrombopag with ATG plus cyclosporin. Next slide. Next slide, please. So it is basically the practice changing abstract, means practice changing article that ATG plus cyclosporin plus L-Thrombopag has been recently published into the phase 3 in that NEGM journal that you should incorporate in your clinical practice. So now moving to the adverse effect, because all of the drugs have some adverse effect. So what about the adverse effect of the L-Thrombopag? Dr. Siva, what is your opinion and what is your practice?
Yeah.
So
in my practice nowadays, after this data is published and well documented on triple ATG cyclosporin with L-Thrombopag, I have almost virtually all those affording patients have switched over to this protocol, and they do really well even in a real world scenario. And as far as adverse effects are concerned, basically we are monitoring liver function tests very regularly when these patients are on cyclosporin with L-Thrombopag. And I have seen 5 to 10% of patients in whom their SGPT-OT increase, and in such cases, usually alteration in the dose of cyclosporin usually brings back the liver function to normal level, and with that we can again restart the L-Thrombopag and cyclosporin. So as far as adverse events are concerned of L-Thrombopag during the treatment, apart from the liver function test or impairment, mild impairment in liver function test, I have not seen the severe adverse events patient facing with the L-Thrombopag.
Right. So the GI, in terms of this, the SGOT elevation, bilirubin up to the 5, we can allow it, then we can stop it, as Sima is rightly pointed out. Next slide, please. Next slide. Next slide. So then after giving the ATG plus cyclosporin plus L-Thrombopag, what is the role of this cyclosporin maintenance? Dr. Upendra Sharma, what is your opinion?
So once we have given triple therapy with ATG, cyclosporin and L-Thrombopag, usually we give from L-Thrombopag for around 6 months to our patients. If they are maintaining the response, we continue with cyclosporin for another, say, a year. Then we do a slow taper of cyclosporin. Some of these patients with slow taper of cyclosporin may have relapse of the disease, so they have to keep on a long-term cyclosporin. We have also seen some of our patients wherein when L-Thrombopag, those patients were not responded properly to the triple combination having partial response, then we do increase the duration of L-Thrombopag from 6 months, and we further give this therapy with the cyclosporin and L-Thrombopag with the prolonged duration of therapy.
Right. Next slide, please. So Dr. Upendra is absolutely right. So we have to continue the cyclosporin therapy, because if you interrupt the cyclosporin therapy, there the chance of relapse is there. Usually our practice is that 1 year you have to continue the cyclosporin, then subsequently another year we have to taper slowly down the cyclosporin if it is responses is there. Next slide, please. Next slide. Next, come to the in terms of the clonal evolution, because you know the immunosuppressive therapy, there is always chance of the clonal evolution is there. So now moving to Dr. Vikas Goyal. So what is your the pointer in terms of this risk of clonal evolution with this use of immunosuppressive therapy? Dr. Vikas, please. Is the Vikas is there? Dr. Vikas?
Yeah.
Please unmute yourself.
Yeah. So there was a study done by NIH, National Institute of Health, where they have compared the effect of clonal evaluation regarding to the treatment given. One study took only standard IST, and another group IST plus L-Trombopag. And they have taken about 72 patients, 92 patients, and they have found that out of 92 patients, only 7% has developed clonal evolution, and it was similar to the group who were received only IST. So they have concluded that the rate of clonal evolution is almost same whether we add L-Trombopag to that standard IST treatment or not. So the risk of clonal evolution is the same.
Right. Next slide, please. So Dr. Vikas is absolutely right. There is a risk of clonal evolution always there. The study have been shown that there is 8% risk of the clonal evolution is there. But in the long term of the immunosuppressive therapy, you know that the AML and the MDS and the PNH is the development is the major problem with the immunosuppressive therapy. Next slide, please. So in terms of this use of this L-Trombopag in Indian setting, this has been published that even in case of the Indian setting, if you look for the response rate, though this is a small study of the 22 patients, there is 86% overall response rate is there in case of the 6-month follow-up, and then a complete response rate is around the 30%. Next slide, please. So in terms of this, the improvement relation to the L-Trombopag, it not only the improving the blood count, but also the complication related to this different immunosuppressive therapy and also the aplastic anemia disease per se, and there is a quality of the life. And not only that, by giving the immunosuppressive therapy along with the L-Trombopag, it definitely improving the survival of the patient with the aplastic anemia. Next slide, please. So basically the treatment algorithm of the aplastic anemia is more or less the similar. The transplant option is there. If it is not there, then we have to add the triple drug therapy. Next slide, please. So in take home of this, the infant of this, the L-Trombopag, the ATG plus cyclosporine plus L-Trombopag. In case of the relapse and the refractory setting, the single drug by using this L-Trombopag, the response rate is as high as the 40 to 44%. If we add the upfront setting, the ATG plus cyclosporine plus L-Trombopag, the 3 months is around 90% patients have been responded, and the 6 months is 92% patients have been responsive. But you should be very cautious that you have to continue the cyclosporine. If you don't continue the cyclosporine, there the chance of the relapses is there. And as the risk of the clonal evolution and the AML MDS is always there, so we need to long-term follow-up in immunosuppressive therapy. So in 2020, the treatment of the aplastic anemia, if there is no HLMS sibling transplant is there, we should use the ATG plus cyclosporine plus L-Trombopag together to improve the survival of the patient with aplastic anemia. With this, thank you very much. Next slide. And thanks to all panelists for the wonderful discussion. Over to Agarwal sir, please.
Thank you so much, Professor Tufan and the panelists. We'll move on to the last session of the day, which is on chronic myeloid leukemia. Once again, this is supported by Novartis. We have a lecture, 15 minutes duration, by Dr. Jina Bhattacharya. The title of the lecture is Chronic Myeloid Leukemia, Hit Hard and Hit Early. Dr. Jina Bhattacharya is MD Medicine from Guwahati Medical College, PM Clinical Hematology from AIIMS Delhi. She is Professor, Department of Clinical Hematology at Guwahati Medical College and Hospital, Guwahati. Over to Dr. Jina, please.
Thank you, sir. Good evening, everyone. I'll share my screen. Are my slides visible?
Yes.
Yeah, good evening, sir. Good evening, everyone. I'd like to thank Mumbai Hematology Group and specifically Professor M.B. Agar sir for giving me this honor to speak before you. My topic today is chronic myeloid leukemia, and I'd like to see or discuss through the next few minutes to see which patients of CML and to whom to hit early at diagnosis and hit hard. So through the next few slides, I'd like to discuss about this, to whom we target to hit hard at diagnosis. So we know that chronic myeloid leukemia patients has achieved nowadays a life expectancy which is as good as any healthy individuals. And therefore our aim to treatment is to give them a survival with a very good quality of life. So with the introduction of TKIs, this has been possible. I'd like to start with a case study, which is a patient of 30-year-old female, married for 1 year. She presented to us with complaints of generalized weakness and awareness of mass in the left upper quadrant for about 3 months. Clinical examination revealed a splenomegaly of 10 centimeter below the costal margin. The CBC revealed a WBC count which is 87,000 per cubic millimeter with a hemoglobin of 10.7 and platelet count of normal 1.5 lakhs. When we looked at the peripheral blood smear, it revealed a CML in chronic phase. The plus percentage of in the peripheral blood was 5%. Bone marrow was done and it showed a disease to be in chronic phase. Cytogenetics had confirmed the presence of phase chromosome in 100% of the metaphysis analyzed. And so this confirmed that this patient has CML. BCR ABL was 72% at diagnosis. And when we try to do the risk stratification as per ELTS score and as per SOCAL, both had revealed a high risk of disease. So our final diagnosis was CML in chronic phase with high risk of disease. While taking the personal history, she had no prior illness and she was not on any medication, but all the biochemical parameters were within normal limit. So once with the diagnosis, we sat down with the patient and the family for counseling about the disease, about the prognosis, treatment options, and the goal of treatment, the toxicity of the treatment, and so on and so forth. So as we all know, first line of treatment options for a newly diagnosed chronic myeloid leukemia and chronic phase is TKI, tyrosine kinase inhibitor. There's no doubt about it. Only in specific situations, nowadays we consider allogeneic hematopoietic stem cell transplantation for cure of the disease. So the options of TKI in front of us are 4, which is available in our market, and we can give any of these molecules to our patients: imatinib, nilotinib, dasatinib, bosutinib. Even though we are confident about imatinib, but we have options for all the rest with us. So the question that arises to our mind always while dealing with a patient at diagnosis is which one to choose. And it depends upon many factors. We know about it: comorbidities, side effects, availability, but most important factor is treatment goal. What is the goal for treatment for that particular patient? So when we consider treatment goal, first thing we need to achieve is that patient has to, we have to get a deep molecular response, which will transfer into a consideration of treatment-free remission. And the rest of the parameters will be, obviously, will come along with these 2 goals. So basically, whenever we have a patient, young patient with high-risk CML-CP, so we have to have, our aim is to get a very fast and deep response as early as possible, and so that the patient doesn't progress into accelerated phase or blastic transformation. Patients should be having a quality of life with limited treatment-related toxicities, which lead to increased survival with a good quality of life. And finally, our aim would be to have a treatment-free remission, probably a cure. So most important parameter in this is whether how we can achieve early molecular response. It's a very important predictor of response later on. Therefore, this is very important that we try to get an early molecular response. What do you mean by early molecular response? Early molecular response is BCR-ABL by RT-PCR should be less than 10% at 3 months. And so this has been seen more in cases of second generation TKI instead of imatinib as a first line, when we use imatinib as a first line. So when imatinib was used as a first line, when we start treatment at 18 months, it has been seen, as you can see in these three graphs, there are three risk groups: low risk, intermediate risk, and high risk. And in this risk, as you can see, response in terms of cytogenetic response, progression-free survival, or overall survival. In the high risk group of disease, irrespective of that time frame or risk group, you can see all the high risk patients or intermediate risk patients had lower response in terms of complete cytogenetic response or survival response. So this particular observation has led to think about newer molecules of TKIs like second generation TKI. So we started thinking of a second, even though imatinib was giving a good response, we were getting a 80% survival over 10 years. However, for a certain group of patients who are intermediate risk and high risk, we are not getting as good response as we wanted. Therefore, we started looking out for second generation TKI to give as a first line of treatment in specifically young patients with intermediate risk and high risk group of disease. Therefore, we need to let us look at imatinib versus the rest of the TKIs, and which of the patients we should hit hard with this second generation TKIs. So when we look at the disease risk and diagnosis, it has been shown in various studies that to achieve an optimal response for this high risk group of diseases, it is a challenge. And this has been established by different studies like NS study, which compared imatinib with nilotinib, and decision study which compared dasatinib with imatinib, and before study which compared bosutinib with imatinib. And all these studies has shown that to achieve MR of 4.5, which is the ultimate goal, is much more in cases of nilotinib and dasatinib and bosutinib. Therefore, this particular group of disease where this is high risk, imatinib has lower response than the rest of the 2G TKIs. And this has been established beyond doubt that 2G TKIs are the drug of choice for high risk disease and intermediate risk disease. And it has also been observed that those patients who had additional chromosomal aberration, when we used 2G TKI in this group of patients, they had a similar outcome as it with normal karyotype, no additional chromosomal aberrations. So NS study has shown here, as you can see, the BCR-ABL, the early molecular response was seen across all risk groups. However, this is more evident in the high risk group of diseases. And this has been established at a follow-up of 5 years also. High risk disease and intermediate risk diseases has a better overall better molecular response than low risk disease or than imatinib. So, does this translate into survival outcome? Do we look at overall survival and progression-free survival in second generation TKIs? It has been seen that irrespective of whether this is first generation or second generation TKIs, it is similar across all TKIs. So far, whatever studies we have conducted and decision before, all studies have shown that overall survival outcome is similar across the TKIs. However, recently there is a prospective cohort study in Japan, which is a new target study, and they have shown a better outcome with 2G TKIs. 5-year overall survival of 90% in imatinib group, 94% in dasatinib group, and 98.4% in nilotinib group. This is the only study which has shown a better response of 2G TKI in terms of overall survival. So when we consider EMR, that is early molecular response, as I have told you that early molecular response is the best predictor for subsequent responses. And this is a very important surrogate marker to predict overall survival irrespective of the TKI used. And it is also a surrogate marker for achievement of MMR, which in turn would make the patient eligible for consideration of treatment-free remission. And so this has been seen in two studies, NS and decision studies, that early molecular response is significantly higher than imatinib when it is used in CML in chronic phase at diagnosis. And this has also been shown by the Japanese study, new target study, that overall survival is also significantly better when we use these second generation molecules at diagnosis. And therefore, recently, ELN 2022 has recommended the change of TKI if we do not achieve EMR at 3 months, which is less than 10% of BCR-ABL percentage. And so this MMR achievement is also predicts a sustained MR of 4.5, which relates to deep molecular response. And when we achieve MMR early and at recommended time points, then sustained deep molecular response possibility is higher. And if MMR is not achieved at a time point, if the MMR is suppose no MMR at 12 months or 18 months, then achieving MR of 4.5 is only 14% and 6% respectively. Therefore, it is very important that we achieve MMR at time point, and this is possible with the 2Z TKIs. Time to achieve MMR also predicts stable maintenance of MR 4.5. And this has been shown in a 10-year follow-up study that those patients who has sustained MMR of 4.5 is eligible for treatment-free remissions, and a higher number of patients are eligible for treatment-free remission with nilotinib than imatinib. So when we looked at the disease progression, it has been shown that the disease progression is slower, or the 2Z TKI suppresses disease progression to AP or blastic transformation. And this has been seen in a recent trial of 6 large clinical meta-analysis trial, and disease progression was lower when 2Z TKI were used. And when we look at it, survival in consideration of imatinib versus 2Z TKI, as I have discussed, NS and 10-year follow-up, decision follow-up, and before follow-up, and recent meta-analysis of 6 large trials has shown that the significant survivability was not there. However, the recent trial that I have already mentioned has reported significant change in patients where nilotinib and dasatinib was used at the front line of treatment in CML-CP, specifically those patients who had high risk of disease. And the age and comorbidities are previously we used to consider those patients who had older age and lot of comorbidities will probably not use 2Z TKIs, which has changed now. And nowadays 2Z TKIs are used in elderly patients also, and those patients who have comorbidities with very good results. And specifically, this is important that those patients who are elderly and with comorbidities would like to discontinue treatment to lower treatment-related toxicity. So for them, to desire TFI is more important. Therefore, for these patients also nowadays, we consider giving 2Z TKI upfront. And obviously, during pregnancy, there is no doubt that those patients who, suppose for our patients who is 30-year-old only and married, she would like to become pregnant soon. And for these patients, we have to achieve very early molecular response and deep molecular response so that these patients become eligible for treatment-free remission criteria, and patient can be given that option for treatment-free remission so that patient can then plan pregnancy later on. So once we know now that for high-risk patients and intermediate-risk patients, we have to go for 2Z TKI for a better response and final outcome, good outcome. But which 2Z TKI is to be used? Because as it has been seen across the trials that nilotinib, dasatinib, bosutinib, all three had similar overall similar outcome in terms of response. So there is no difference in response and survival. However, there is no head-to-head trial to compare between these groups. And however, in a phase 3 multicenter trial in Japan, nilotinib versus dasatinib was seen, and this trial was reported in the 62nd American Society of Hematology 2020 conference, and they have reported that MR of 4.5 was the primary endpoint, and PF and OS was secondary endpoint, and these were comparable in both the groups. And difference is only adverse events. Nilotinib, as you know, we have to see the adverse events, consider adverse events and comorbidities, and accordingly decide on which TKI to be given. And so we started our patient with 2G TKIs, nilotinib twice daily, tolerated well. At 3 months, she had a very good early molecular response. Our goal is to give her TFR soon. So in summary, treatment goal for CMSCP patients is survival with good quality of response. TFR is recommended irrespective of age and comorbidities. And therefore, so because the target is to give TFR, EMR, early molecular response, major molecular response, and deep molecular response are achieved significantly in higher percentage of patients with 2G TKI in patients who are HR at diagnosis. And therefore, this has been confirmed in different studies. Early molecular response and molecular response and deep molecular response are all predictors for eligibility for treatment-free remission. Choice of TKI depends on different factors. Risk of diagnosis is very important besides the other factors. And choice of 2G TKI depends on adverse events. We have to consider the adverse events and comorbidities of the patients and finally decide, and also availability, of course. We decided to give nilotinib for our patients because it is available given free of cost in our hospital. And for a young female patient who is to become pregnant, 2G TKI is the choice to have a faster and deeper molecular response so that she can be taken for TFR at the earliest possible time. With this, I'd like to thank you all for your patient sharing. Thank you.
Thank you, Professor Jina, for convincing us that hit early and hit hard is the way to go. We will now introduce the moderator for the panel discussion and our panelist. So our moderator is Professor Dr. A.K. Tripathi, MD, FRCP London, FRCP Glasgow, FRCP Ireland, FAMS, FICP, FISHTM, FIACM, Fellow WFHN, Fellow NIH US. He's Professor and Head Department of Clinical Hematology at King George's Medical University, Lucknow. Formerly, he was Director at Dr. RML Institute of Medical Sciences, Lucknow, and he's past President of Indian Society of Hematology and Blood Transfusion. His panelists include Professor Chandrakala from Mumbai, Dr. Suman Pramanik from Delhi, Dr. Sujit Kumar from Varanasi, Dr. Abi Ibrahim from Chennai, Dr. Sandeep Saha from Kolkata, and Dr. Stalin Bala Chaudhary from Hyderabad. Over to Professor Tripathi.
Thank you, Professor Agrawal, for a nice introduction. And we have just listened to a very lucid talk by Dr. Jina, and she has very clearly shown the indications for second generation TKI. So I welcome all panelists, and I'm fortunate to have 6 panelists at the board, and would like to cover certain other intriguing issues related to management of CML. So is Dr. Chandrakala here?
Dr. Chandrakala has not joined.
Okay, so let me start with Dr. Suman Pramanik. Dr. Suman Pramanik, yeah, he's here.
Yes, I'm here, sir. I'm here.
Okay, I'm audible? Yeah.
Yes, sir, you're audible.
So, you know,
Dr. Tripathi, you have any slide to share or direct?
No, I don't have slide.
Okay, sir. Okay, continue.
I will discuss. The goal of treatment is to achieve deep molecular response, but there are certain patients who achieved complete cytogenetic response at 12 months. And if there is no goal for going for TFR, is there any reason to change it to other drugs, second generation, or should we continue with the same? What is your opinion?
In our routine clinical practice, we see patients who are who don't aim to achieve the deep molecular response or TFR. So in those patients, I think imatinib, that is first line, first generation TKI, and if patient is achieving more than major molecular response, and he is continuing to do so, then I think there is no harm in continuing the patient on imatinib in these type of patients.
Yeah, because studies have shown that there is no improved survival if you change. So that means you try to achieve deep molecular response, particularly in those group of patients where your goal is TFR, right?
Exactly, sir. Exactly.
Yeah. So my another question is to Dr. Sujit Kumar from Tata Cancer Hospital, Varanasi. Is Dr. Sujit here? Dr. Sujit. Okay. So Dr. Abby Abraham is here.
Yes. Yes, sir.
Yeah. Welcome. Welcome, Dr. Abby.
Thank you.
The most important reason for resistant TKI resistance is KD kinase mutation. But in some patients, and the cause may be mutation, cause may be some other factors like increased expression of BCR-ABL, or some alternate pathways, or some other mutations like in non-KD USA mutations. And recently we have seen a number of studies showing the results of NGS, next-generation sequencing, finding different types of mutation in CML. So I would like you to shed light on this fact, because sooner or later people would be interested to know and also to practice NGS in patient of CML.
So essentially, one of the earliest ways in which we could see if there is resistance is to look at the milestones achievement.
Yeah.
Or if somebody has achieved a milestone, they have lost that response. So loss of response or failure to achieve a milestone will alert one to the possibility of an underlying mutation. And you could check for the mutation. And if the mutation is not found, it does not mean that you can continue with the drug. You could potentially change the drug. And depending on what the patient, you have to tailor that. Now that we are spoiled for choices, if financially you could choose any TKS, so you have to tailor it to that particular patient and use it. And NGS, of course, is still not come into the regular algorithm. I suppose NGS might help us in picking up these patients earlier.
Hello. Hello. Yeah.
Yes.
Dr. Sandeep Saha is here from Kolkata.
Yes, sir. I'm here.
Yes, sir. So we have just listened lecture by Dr. Gina, and she has beautifully described the indications of second generation TKI, including intermediate high risk CML, including those patients who aspire to have this TFR. Can you tell me other indications where essentially the choice is second generation rather than first one? Other than that?
Sir, actually, to change from first generation to second generation depends on the age, tolerance, comorbidity. These are this condition should be considered apart from the usual nature of change, like any mutations or anything, mutations or sometimes the failure of the milestones.
Yeah.
But apart from that, we consider these things, whatever I've said, the age, tolerance, comorbidity.
There are different types of transcripts. Hello?
Exactly, sir. One thing we should consider, that is a separate thing. That's why now we used to prescribe the BCR-ABL transcript.
Yeah.
It should be reported routinely from the initial diagnostic part. Not only that, because sometimes if we use only the PCR part, sometimes we may miss the atypical BCR transcript. So in that cases, we have to do it with the fish.
Yeah, and I was trying to say that if patient has atypical transcript like E13, A2,
exactly.
Yeah, studies have shown that these patients respond better to
better response.
So,
E13.
yeah, so in addition to so many other indications, this is also one of the indications. and for choosing second line upfront rather than first line. Is Dr. Stalin here?
Yes, sir.
Yeah, welcome. Just we were just discussing. Dr. Sujit was Sandeep was referring to fish. So again, coming to that point, at the time of diagnosis, we do different investigations, and including to demonstrate BCR-AVL, we do karyotyping, we do fish, and also qPCR. So my question is, the relative indications of these, do you like to do all of them, or do you have any priority, or what is the additional importance of fish?
Sir, most of the times our practices do a PCR.
Yeah.
So PCR, most often my institute practices doing a quantitative PCR. So we do the qualitative for the transcript, and the quantification of the identified transcript also we do. Fish only we do in a cases where the bone marrow is definitely, the pathologist says the bone marrow is definitely CML-CP and the PCR is negative. To doubly rule out the CML, we do a fish, because sometimes in some cases, that is only approximately in 1 to 2% of cases, can be PCR negative because of the unknown transcripts, which can be fish positive. So in those settings only, in my practice, I will do a fish. Otherwise, my routine practice is to only BCR, only by PCR and conventional cytogenetics for all the patients.
Let me add another indication. If conventional cytogenetics is not possible, either bone marrow is not possible or there is no growth metaphase, that means it's a failure. Then in order to find out additional chromosomal abnormalities, I think fish is indicated. Do you agree with me?
So I have not done never a fish to identify the additional chromosomal abnormalities in my practice, sir.
Yeah, so but that could be one of the indications where
maybe
where you don't get metaphase during, because conventional karyotyping is not it's a very tedious procedure. And
yes, I do agree, sir.
Yeah, it can be contaminated, there may not be growth.
Yeah.
So yeah, Dr. Chandrakala is still not here.
Still not, sir.
Yeah. Anyway, so can I ask again? The bone marrow, Dr. Stalin. So, do you essentially do bone marrow examination at the time of diagnosis, or in some cases you like not to do that?
Most often times, sir. Most often times we do in bone marrow. So we had a data to say also, sir. So which we have presented in the ESMO conference, and we are preparing the publication ready for it also.
Yeah,
so a data of 700 cases of CML, there is a chance of the upstaging of the disease from CP to AP and BC, or AP to BC or BC in approximately 5 to 6% of the cases, sir. So not to miss them. So, and also collect a good material for the cytogenetics. And we had a presentation in ASH 2018 regarding the myelofibrosis impact on the MMR rates at 1 year. So which can be known only on the bone marrow. So presence of a grade 3 and grade 4 reticulin and myelofibrosis had a prognostic impact by less attainment of MMR at 1 year. So to know all these and for an effective prognostication of the patients, definitely we essentially, almost in all cases, we do a bone marrow aspiration and biopsy at diagnosis, sir.
So in the same, for bone marrow, would you shed light on some role of or importance of having additional cytogenetic abnormalities? And,
yes, sir. Yes, sir. We had a.
What are you finding in our study? Yeah.
So in our study, the presence of additional cytogenetic abnormalities is only approximately 6%, sir. So majority are trisomy 8. Two cases had a double PH chromosome. And recent WHO has had said that presence of an additional chromosomal abnormalities can be kept as AP at diagnosis. So by that criteria also, some more cases has been transformed from CP to AP.
Which one?
The recent WHO classification of CML, the presence of additional chromosomal abnormalities at diagnosis could be labeled as an AP. One of the criteria.
All
no, sir, only major root abnormalities like trisomy 8, trisomy 19, and double PH chromosomes and isochromosome 17. Only for we have checked only majority of the times only these abnormalities. Sir.
Yeah, so now my next point is open to any of you, expert panelists. Experience about low dose dasatinib 50 milligram a day. Yeah, any one of you can answer?
Yes, sir. We have experience. I belong to NRS Medical College.
Yeah.
Actually, we are giving in many patients of low dose, that is 50 milligram once daily. And we are going to publish that one. That's why I'm not disclosing all the facts. But my opinion is it's really working. Only this much I can say. And we are happy.
Yeah, and what about Dr.
So far the CP is concerned.
Yeah. Dr. Pramanik, your experience?
Sir, again, sir, we are part of a study, sir, a GLAD study with Dr. Abby Abraham, sir. He's the investigator.
Yeah.
So we are part of it. So I think it's okay. But again, because it's still in the process, so we will not be able to disclose, or we do not know exactly what is the result for the same. So.
Okay, so Dr. Abby, what is your opinion about future? Because you know that not all patients can choose for TFR, and those who choose TFR, only less than 50% around, they have long-term remission. So that means still long way to go before we can say that CML can be cured. So what is your hope or your expectation? What is going to happen within 2 years in order to increase the chance of having CML cure?
I think there are newer molecules and there are new ways of targeting the CML leukemic stem cells.
Yeah.
A few years ago, we had that data coming about pioglitazone, and it has definitely worked towards complete molecular response in patients who are not achieved that. So obviously, there will be more and more such targeted molecules available, which are fairly very cheap and which can be added to TKA. There are other drugs as well, like the STAMP inhibitor, the asciminib, and all. So those in combination with TKA might be another potential way of targeting this. I'm really hopeful and that we will be able to have a better outcome if you are targeting TFR in the very near future.
Yeah, you have raised a very pertinent point of repurposing of drugs. We had some basic studies using clofazimine, that is anti-leprosy drug, and also pioglitazone. So there is a need for studying such drugs so that we can kill leukemic stem cells, because these stem cells do not optimally respond to imatinib or TKIs. So definitely, although CML is now chronically manageable disease, but our goal is to have a cure, and for that, definitely in future we will have some new drugs which could kill leukemic stem cells, so that we can make sure that CML is cured. So in the last, I would invite any more comments from our expert, from panelists, before I close. If it is not, then let me have privilege of thanking all of you, and also thanking Professor M.B. Agrawal for giving me a chance to moderate and to have discussion on the subject with all of you learned persons. Thank you. Thanks a lot.
Thank you, Professor Tripathi, and all the panelists for a wonderful discussion. Enjoyed listening to you and learned a lot. And thanks to Novartis for this whole 2-hour session of covering 3 important diseases in hematology. We had a wonderful evening. And thanks to Mice Ideas for managing this show flawlessly. So with that, good night. Have a wonderful dinner. And those of you who are interested in joining us tomorrow, 6:30 again. Thank you. Bye-bye. Good night.
Thank you.